let's just start the program. Actually, if you don't mind, let's go over your cases that you want to present, and then Dr. Schultz has a very interesting case, a little, multifaceted. But can you share your pictures, or do you want to email it to me? How would you like to share the pictures?
I think I'll email them to you right away. I think I sent you an email yesterday, but
Okay, let me go and look for it. Actually,
I sent it at Hamid at H Abbasi at Inspired Spine.
.org. Okay, I have to go to that account. Let me just go there. And here they are. Okay, let me share them. Okay, nice. Go ahead, actually, enlighten us.
So this gentleman is a 71-year-old gentleman, lots of medical comorbidities.
Excuse me, everybody seeing the pictures?
Yes, I can see it.
Okay, good. Okay, go ahead. I'm sorry.
Right. So no worries. And then so he presented now, he had a history of L3 to L5 laminectomy that was done about 20 years ago for neurogenic claudication, presented now with severe neurogenic claudication-like symptoms and bilateral L5 to S1 radiculopathy as well. He has a right foot drop that has been going on for many years, and over the years has tried significant physical therapy, injections that give him brief relief, but now at the point where they don't help him much. So we have a CT and an MRI both for him. The CTs, you can see the sagittal images. The first on the left on the top is the midline that I tried to get. He not only has obviously vacuum disc at multiple levels, but he has calcified disc herniations and osteophytes that have kind of happened over time. And the picture on the right of the top is, I think, his right side, where you can see this complete almost collapse of the foramen. The coronal picture was added to just explain that there's osteophytes also in the front that or on the sides that I have built over time, and doesn't have much of a deformity there. But in the right picture at the bottom shows that with the laminectomy, I think he's got some facet overgrowth over time and complete stenosis at that level. And that's a 4 or 5 level stenosis that's he has. There's a second picture, I think, as an MRI that
Move on. Tell me when I need to move on. Okay.
Yeah, that's it. So just same kind of pictures, midline MRI showing the stenosis. That's L4-5 on the top right, and L5-S1 area on the left side. And I think, and that's this coronal picture. So it's kind of a really tough situation where he's got a combination of lumbar stenosis from the osteophytes, from the previous laminectomy and regrowth of bone, as well as foraminal stenosis. He came to me because he was offered a lumbar 3 to S1 operation by another surgeon, which I think is reasonable, but at the same time, the posterior compression makes me nervous. The amount of bony overgrowth that he has. So just wanted to see and bounce off you all to see what you guys think could be offered for him. Maybe something is a hybrid, maybe staged, or and he's 71.
Healthy otherwise?
Has some medical problems, not unreasonable. I mean, he's got some cardiac history, but he's been cleared by the cardiologist.
Okay, cleared by the cardiologist for a 3-hour surgery or for 8-hour surgery?
For 3-hour surgery.
For 3-hour surgery. Good. Well, let's open the floor for everybody. Burhan, welcome. I'm not sure if you see the picture or see the first picture. So based on the clinical information you got, what do you think?
Good morning. Yeah, I'm sorry. I just popped in.
Don't worry. Then let's go to Peter. Peter, what do you think?
Yeah, first of all, what's his main issue? Low back pain or radiculopathy or combination of both?
Combination of both.
Combination of both. And it's main to L5 and S1 on both sides, right?
Correct.
Okay, good.
Just throw out what you would do. That is really no right or wrong answer. We know that there are so many different ways to deal with that.
I'm sorry. Yeah, I'm not looking at it. I think it might be parasagittal, but there's a lot of disosteoid complex from L3 to L4-5, isn't it? And then some fractional curve there
Yes,
with disosteoid complexes. So, I mean, I think in a nutshell, we have to address the pathology from L3-4 to L5-S1 level in this case. I haven't seen the axial sequence at L5-S1, but so the options could be, you know, in the setting of fractional curve, you know, I think fusion is reasonable because there's a significant decrease in disc height loss and foraminal disease. So merely laminectomy or decompression would not be optimal in this case. So I think, you know, interbodies probably L3 to L5, and those can be done based on, you know, I know he's 71 and stuff like that. So the current options could be, you know, addressing 4-5-5-1 and L3-1 from either anterior or lateral approach, or doing L5-S1 and then L3-4 lateral, and then bring him back in for a percutaneous instrumentation or open. And his BMI is not high.
no,
Yeah, then probably bring him back in and then fusing him from L3 to minimum L3 to S1.
What method? Open TLIF, just posterior combination?
I mean, so the two options, you know, anterior, you could do a 4-5-5-1 anterior axis and do the anterior surgery, and then 3-4, you know, you could do at the same day through a lateral approach. We do a ALF and then followed by a lateral. I think this is kind of the main workhorse most of the people do. Some people start doing a lateral at 3-4-4-5 and 5-1 anterior first, and then quickly flip the patient and do the 3-4-4-5.
Do you think that can be all done under 3 hours?
No, under 3 hours. Probably I would say it's kind of a minimum 5.5 hour surgery, and then you bring them back in. So typically what I do is I bring them back in for the second approach, which would be a day and a half after, and then instrument them from the back.
Okay. Naveed, what do you think?
Yeah, I agree. My opinion is the same. I believe that the patient needs L2 to S1 fusion and interbody fusion. I prefer L5-S1 ALIF, and for L2 to L5, although it is difficult, but in my hand is TLIF. I will do TLIF, posterior TLIF, and L5-S1 fusion on ALIF. So,
Dr. Fatih, any additional approaches that you would do?
Salam to all. I'm sorry, I just joined the session and I am absorbing what you say.
So, actually, I know that you have a plan and you just want to get our opinion, and I think there are 20 different ways you can treat that, and each of those ways is going to be different in different hands, based on your familiarity, based on your experience, based on your surrounding, and so on. And most importantly, based on many details that it's impossible for you to share right now. I want to show you something. I just looked it up in my blog. This is not your patient, but it's very similar. And this is as well not your patient, but very similar. And I get about 5 to 8 of these patients a month. And the average age of those patients is 82 years old. That I get multi-level problem and so on. I'm just going to tell you how I deal with that. And obviously that's just one way of dealing with that. And that works in my hand. Wouldn't work in somebody else's hand. First of all, I identify what kind of surgery they are like. Do they have heart problem? Are they fragile? What kind of, do I need to do a 1 hour surgery or can I do a 3 hour surgery? What the impact of that would be on their recovery? Generally, I avoid. Can we please Bob, can you please mute it? Generally, I avoid any surgery longer than 3 hours in elderly. That is, and that's based on lots of data that the complication is linear until 3 hours, but after 3 hours in elderly, it's literally exponential, the rate of complication. So if I have to do something more than 3 hours, I do stage it. And that reflects as well Burhan's and probably some other people that there's nothing wrong with staging a case, absolutely nothing wrong. So once I decide if it's a 1 hour or 3 hour surgery, then I go back to see what do they really need. Like this patient, I'm going to show you what I did for this patient. I did a 3-level fusion, whereas this patient, I did a 5-level fusion. By the way, this 5-level fusion was about 2-hour surgery. And this 3-level fusion, I just did this is not what I did 2 days ago, but I did one of that in 65 minutes. So I have more option because my system support me to be very efficient in that. So I can tailor it to what really patients need. But then it goes back to the main question, do I need to do a direct decompression or not? And that makes a huge difference, obviously, because if you have to do a direct decompression, it's going to be a longer process. My decision, how I decide if I need to do a direct decompression, is based on few factors. Number one, if there's osteogenic stenosis, and in your case there is, I think there is. What do you think?
Yes, I agree.
And number two is if patient has symptom of claudication all the time, or it has symptom of claudication only with excessive activity and stand up, because I'm hoping at least, not the combination, what kind of surgery patient can get versus if the symptom of claudication is all the time there, then there's no question. You have to do a direct decompression. But only if the patient stand up after 15 minutes, let's say, they have claudication symptoms, meaning that when they lay down and put no pressure on that segment, that they can manage it, even though it looked bad in the picture. And today I'm going to show you 2 cases that, I mean, at least for me, I treat patient and the symptoms and not the picture every single time. Let's say picture looks horrible, but patient sit down, has no symptoms, start having symptoms 15 minutes after they walk. Can I create a situation in their spine that even when they stand up, the spine look like they're laying down? Can I fix it in that position? Now, if there are cases that I do my procedure and then I do a mini opening, I take the lamina off, I still do that, but do I need to do that? So these are a combination of and there are lots of subtleties that's impossible for you to share with us. So your question is, what is the best approach with this? Based on what you described, this is one of the patients that I would do literally, when the patient sits down, does patient still have radiculopathy?
No, his primary symptoms are mainly like he used to walk a lot and now he can barely walk a block.
Okay.
Yep.
So
the radiculopathy symptoms are present even at rest and sitting, yes, but the question you asked about claudication is mainly during activity.
So if the symptom of claudication, if radiculopathy is still there when he's sitting down, a patient sitting down, then you need to do one kind or another kind of direct decompression. Then what I would do, and I have done plenty of that, I would do a foraminotomy or laminotomy and just watch the patient. And then usually leg pain get better, the back pain doesn't. Then I go 2 months later, I do a L3 to S1 OLIF procedure. In rare cases, when I just want to get everything done at the same time, I do a L3 to S1 OLIF, then I do a small midline and I do a direct laminectomy. Very limited though. One of the things that I learned 20 years ago, there was a surgeon in Houston. He would do a laminectomy. I have never seen anybody since or before and after doing that. And it makes so much sense to me now. At that time, I was a resident. I thought, you're a crazy person. Why are you doing this? He would do minimal opening and just take bites as he goes, and he would disrupt the muscle as little as possible. Whereas all the other would just do a wide opening and cut everything and so on. But he would do very minimal. 20 years later, I came to his wisdom, how limited, how minimally he disrupt the muscle to do his laminectomy. And that's what I do now. That if there is a symptom of claudication and radiculopathy, I do still my fusion, but then I do a minimal midline incision and I remove a spinal process as lamina as little as possible to do that. But in your case, I think do whatever you feel comfortable you can do in 3 hours. And but in the way you described it, this patient does require a direct decompression.
If you see the CT scan on the previous picture,
Go
that
to the previous picture.
facet overgrowth, the axial cut, that I think that is where also his significant stenosis and compression that he experiences going on.
Yes, it is.
So I have two questions for you. One is obviously on the coronal image, we see the osteophyte complex. So if you're doing an OLIF, trying to break that or trying to tackle that, how would that be? Or I think, and then secondly is,
I'm sorry, is that osteophyte only in 2-3 or is it every level?
it's every level. They're subtle, but they're every level.
Okay. Okay.
And then if you look at that sagittal picture, he also has the calcified osteophyte or disc complex.
Yeah.
And how does, if you try to expand that with an interbody, how does that factor in? Because now I've seen almost 3 patients now in the last 2 weeks, Hamid, that have these calcified disc, and it makes me wonder, would indirect decompression even work in those patients? Because that complex is not going anywhere.
Let me put it this way. I don't believe it's by chance that you see the vacuum effect in L325S1 and not in 2-3, not much of it in 2-3. I don't believe that's random. I think that says something that whatever osteophytic fusion it is reducing the motion in those levels, and those levels that have vacuum effect, they truly have lots of pathologic motion still left in them. So that is my thinking. That's why in this case, I wouldn't approach 1, 2, and 2, 3, at least not initially. But I do believe, every time I see vacuum effect, I believe, or I want to believe that there is a mechanical process that bone hit the bone, damage the cartilage, and this is a mechanically decomposing material of the disc. So in the fact, I can tell you the fact, I treat again 5 to 7 of this a month. Only in 5% of them I do direct decompression. This is the fact. I don't know how this patient is going to do, but this is the fact that in less than 5% of those patients I do direct decompression. 95% of them get better with indirect decompression, but those are all people that I choose selectively. I make sure when they sit down or lay down, they have no radiculopathy. They don't have any, constant pain in their legs.
Sorry, if you do an indirect decompression, would you ever go back and do a direct decompression if symptoms don't resolve?
13 cases in 1,500 cases. No, there are many cases that I say I do first decompression, then I do the go fusion. There are many cases I do fusion and I do a midline small limited decompression, mostly for grade 2 spondylolisthesis. But there have been 13 cases that I wasn't planning to go and do direct decompression, but within 3 months I have gone and I've done a direct decompression. From those 13 cases, by the way, 13 cases from 1,500 cases, from those 13 cases, 5 fell and had an accident. And this is the statistic. So yes, absolutely. Sometimes what I do is not enough and I have to go and do a direct decompression. But again, Gupta, actually, this won't work in your hand. This works only in my hand. And this is my statistic, okay? If you don't have my team, if you don't have my system, if you don't have my, the experience with the indirect decompression, that wouldn't work with you. But I have been really able to sort of gouge it that I used to over distract, literally put the bigger cages in, and then they would do well. And then 2-3 months later, they just move hard, cage subsides, and then the symptom come back. But I don't necessarily take them right away for surgery. I give them still a little chance to recover without surgery. But as we talked about, in 13 cases, just waiting and doing conservative therapy wasn't enough, and I had to take them back for a direct decompression.
May I ask a question? Dr. Abbasi, may I ask a question?
Yes, please.
Regarding the biomechanic standpoint, do you believe L4, L5, and L5S1 is stable or is unstable? And how about the L2, L3? Because the horizontal sulfide it reflects a kind of instability, but I see that there is very narrowing disc space and the osteophyte are fused together. What do you think about this regarding the stability of the?
No, you're talking about Akshay's case, right?
Yes.
Okay, Akshay, that's a question for you to answer, not for me.
Sorry, ask that again. Sorry, I missed it.
I'm asking about the stability. What do you think about the stability of L4, L5, and L5S1 for this case? Do you believe it's stable or unstable?
Well, we did get flexion extension X-rays. There's no macro instability that's evident, but you can see the vacuum phenomena there. That makes me think that and the amount of facet arthropathy that he's had makes me think that over time he's had that, and that has been one of his major problems. So, if you consider objectively flexion extension X-rays, those are being stable. There's no movement on those.
Okay, actually, should we discuss your second case?
Sure, absolutely.
No, let me just move forward then. Is that your second case?
Yes.
Oh, juicy.
So-
Love this one. Go ahead.
Well, this is a 54-year-old gentleman, fairly healthy. He had a Coflex done and a 4-to-S1 right-sided approach into bodies placed. This was many years ago. Over time, he developed a right-sided foot drop and has extreme radiculopathy on the right side at 5 and S1. An L5 injection helped him significantly for a brief period of time, but now arrives again with right-sided L5 radic. And he was referred for tackling this. Now, I know I've seen a few of these Coflex patients now who have such kind of an bony involvement that happens, but to me also, if I thought of going and taking out the Coflex and dealing with that, but the interbodies specifically placed from the right side bother me, and that pelvic the tilt as well is an issue. Even if I can't show it here, but I got a CT of the pelvis that shows that that's not a good angle for doing an L5S1 anteriorly.
Yeah. May I ask you a question? What is that interbody? I cannot identify it clearly. What is it?
I don't know. I don't know what company that is. It seems like a very small cliff kind of a device that was placed. I don't even know if it's expandable or what the purpose of it is.
Yeah, but it looked the way it looked in the sagittal and axial, they almost don't fit. That is like, is it peak? I think it's peak, but it has, it just look nothing that I'm familiar with. And as well, look at that massive facet growth, but still you see that separation still there.
Yep.
This is now, what is the main symptom? Radiculopathy or back pain?
Radiculopathy.
Okay, so let's open the floor. Based on these symptoms.
There's an MRI as the next picture to do maybe in some of that. Yeah, so that's his. You can see there.
Is this post surgery? That look almost like this MRI.
Yes.
Like, okay.
Yeah.
It doesn't look as bad as CT, but
No.
Yes.
And here again, you know, you see in our protocol, everybody get an MRI and a CT. And now you see why. There are different information that you get from both. Let's open the floor. Bob, you want to comment what you see and what you would do? We have few more cases and we are half an hour through. So let everybody give a short opinion and then we reconcile them. You're muted, Bob. You're muted, Bob. Okay, John, is it? No, I think Bob is muted. So now you're muted as well, or am I?
Okay,
No, there we
I'm
go.
good.
There you go. Bob, you in?
yeah, I'm in. Hey, good to see you, John. Hey, so I think that there is a grade 1 spondylolisthesis at L5-S1. Significant stability. I don't see prominent osteophytes at L5-S1. To me, that L5-S1 segment is unstable. Okay. Then, of course, significant foraminal stenosis that you could identify mostly at L5-S1, but also at L4-5 on the MRI. I believe both of those segments need surgery. I would, to me, I would probably do the following. I would try a left-sided approach, and I think that I could leave those cages that are in there actually, and I would use your bullet cages and get them there from the left side, and do an O-lift with screws L3, L4 through S1. That's what I would do, 2 levels, and I would hope that I could place them so that I wouldn't interfere with the cages that are there. That is what I would try to do.
Okay, Naveed, what would you do?
It looks like something like pseudoarthrosis or non-union at 2 levels, and it makes maybe the possible reason for the symptom of the patient. And I prefer to address that issue, the posterior decompression, and maybe when anterior approach is failed, we can do the posterior, just the secure posterior decompression and secure posterior fusion.
So posterolateral decompression and fusion.
Yes, exactly.
Okay.
Yes.
Peter, what do you think?
I would also go for direct decompression first and then fusion at the same time or in the second stage, but this patient is not too old, so I think he can tolerate a bit longer procedure.
And sorry to interrupt both you also. You said direct decompression, and previously also said posterolateral decompression, meaning from the right side, from the symptomatic side?
Yes, from the right side, yeah.
Okay.
Okay, so as well posterolateral decompression and fusion.
Yeah.
Okay, Tony, welcome. What would you do?
Yeah, I was just attending a phone call. Yeah, the same. Yeah, I would try to get that foramen opened up,
Okay.
Yeah.
And Dr. Fatih, what would you do?
First, I should mention there is something in the central canal. There's a flick of like a calcified tissue or something, and this sagittal that I see here. So it will need some decompression, central decompression. And there also seems to be instability, although one can comment more correctly if someone knows the type of cage that they have there. But it seems there is instability. So if I could take that implant out and put some bone and try for a refusion there, that will be my best shot. Inshallah.
Yeah. Well, I have learned to, if I have to, but I have learned not to try to get the old implant from interbody out, because every time I try to do that, it has been a big deal for me. But that's just my personal experience.
I would completely agree on this. I think that you can do the left-sided OLEF on this, put in
Yeah.
screws, fuse it, wait, and then return back and do central decompression in second stage. That would be my plan. I would try not to open this because I think that you will get a dural tear. It will turn into a shit show,
Yeah.
I think.
Burhan, what would you do?
Yeah, thanks. It's very interesting to hear everyone's perspective, and certainly, as we all always say, there's a different way to skin the cat. I'm kind of confused. Everyone is talking about instability. I think it's because of high sacral slope. We understand that. There are cages already there. We understand that. So the symptoms I'm understanding is residual radiculopathy. That's what it is.
Yes,
So it's only unilateral. What nerve is involved? I'm sorry.
right, L5.
L5. I really don't think to make this into a big case here. I would address his L5 symptom primarily with the foraminotomy and then see how he does. I know there's an overgrown facet, and I know people want to pull out the previous implants. I would never do that. I think in these people, the minimum is the best. High sacral slope, and probably it was a grade 2 spondy to begin with. And I think that's what I would do, and I would wait and see what happens. And then if patient comes back, then yeah, then obviously open approach or extension of fusion, or whichever the case may be. I think it is an option, but I think I would do minimum at this point. I would not make it into pseudoarthrosis, a big case. It's just radiculopathy. It doesn't have a mechanical axial severe back pain. There is no overt instability on the flex X, and I understand the instrumentation is not fantastic, but I think minimum is best in this case.
Yeah.
I like the idea. My question to you all is, if you look at the next MRI, the next picture, the foramen is so narrowed with the sacral slope and the spondy. Is there, even after decompression, doing a foraminotomy, is there enough space for that? Like, we can take off, unroof it, but what about the fact that there's an osteophyte there right at that corner?
Yeah, that's a great question. So what I would recommend is, in this case, I would do a wide medial fascectomy. I would because anteriorly you could see, suboptimal interbodies there. That's fine, but I would just do a heck of a medial fascectomy and remove all the facet, drill all facet out. I would take off rostral. I would take out the caudal vertebrae, rostral lamina, and the rostral vertebrae, caudal lamina, and then do a wide foraminotomy, and then go all the way to the lateral recess, identify the nerve, and that's it. I've done that. I'm not saying that it is. If you try to do that, it has worked even in fractional curve people. I've done fractional curve people, and knock on the wood that they never returned. So I think in this case, that's what I would do, and then I would see how the patient will behave, and then you certainly your options of extension fusion and major work is there. If you look at the sagittal view, his discs are not, they're not very desiccated. They're hygroscopic signals there. I think you could probably possibly do that. The problem is as Dr. Abbasi said, is the facet arthropathy, and I think that's probably the true classic lateral recess syndrome that you're dealing with here.
Yeah.
If you forget about the other issues.
Yeah, actually, if I may ask you, I always try to make the patient my partner. You have talked to this patient. If you would take the leg pain away, would this patient be happy?
Yes.
That's all you're looking for. And that sort of answers that. So obviously, yes, there is a foraminal stenosis, and I'm assuming, and I'm not asking David and Scott because I'm assuming all the conservative therapy is already done, and so there's no question. And even, if in question, I would send it to David. David can put some local anesthetic in that foramen to assure truly this is the radiculopathy. Just because it look obvious on the films doesn't necessarily need to be the only problem. But let's say I send this patient, and is it right or left? Right radiculopathy?
It is right. And we did send him for a nerve root block and he actually responded really well briefly.
Fantastic. So you have done it. So you're sure this is a right foraminal stenosis in that level. Now, let's look at these facets. These facets, even though they are not fused, look at how convoluted they are locked into each other. So I would doubt this level is unstable, except patient has we don't see that here, but except if patient has a pars defect, this cannot be unstable because the way the facets are locked into each other. So if the radiculopathy is the main symptoms, why not think outside of the box? This is the strength of endoscopic, that you can go extraforaminal and then just unroof the foramen until you get into the canal. And then you have opened up the foramen without, minimalistic, as Burhan says, that unroof extraforaminally the foramen, and then until you have created enough, and you would be surprised how little space you need to create for the nerve to be happy. Now, after that, is it enough or not? Or is it the process that continuously produce more bone and narrows the foramen? Is there a macro? The question is, is there a macro instability? I don't know the answer to that, and I think there is. But then, if that is a question for you, then there is nothing that says you cannot do just a posterolateral minimal invasive instrument. I don't have any screws in L4-5S1. You could just posterolaterally do a minimal invasive decompression and then get rid of macro instability that produces bone growth and so on. But there are so many ways to do that. If you ask me, either extraforaminal or lateral to medial or medial to lateral decompression of the L5S1 based on your description is warranted. Fusion is a dealer's choice, in my opinion.
Now, I would probably reverse it. I would fuse it first because I really think it's unstable. And I think that with the fusion and with the interbody spacers, I would probably treat the radiculopathy even if the spacer would go in through the left side.
Yep.
And I am sometimes worried, even if you do it minimal invasive, it's so easy to injure that nerve. So I think that you do it safer if you do it indirect, but that's my opinion. I would reverse it. I would do the fusion first, see what happens, and return to do the probably extraforaminal minimally invasive decompression if there would be residual.
Valid.
I think that's a good, I mean, all these ideas are great. I think what you said last right now is kind of what is resonating with me. So I'll keep you guys updated how this person does.
Yes, please, definitely.
Thank you, appreciate it.
You're welcome. So, David, now we are going to talk about our case.
Okay.
So I'm going to put the films on.
Do you want me to do a little 5-minute preview of the patient and then you can do the images?
Absolutely. Please go
Okay.
ahead. Let me unshare my screen then.
Okay, good.
Jesus, okay, I see where it is.
And
Okay.
may I interrupt real quick? Could I ask you, what are your best technical tips to get the screws into L5S1 in a OLIF fashion with this much of a sacral slope? What are the best tips to achieve that safely?
Is it question for the team, I'm assuming? Go ahead, everybody.
Mostly for the team as well.
Yeah, well, with that kind of slope, I always go one level above. I go to 4. If that's, let's say, if that was the only problem, and I think when Akshay was with us, they actually did that. Patient had a grade 2 L5S1 spondylolisthesis. L4-5 wasn't that bad. With that much of slope, I try to instrument one level above it. But the angle, you can get the screw in, but I just don't trust it. With too much pressure on the screw, so I go one level above.
That makes sense. And how do you technically, if you do an OLIF, what are your technical tips to get the cage in L5S1 and do the screws right?
The beauty with the OLIF is that you set up your pictures the way you get a true AP and lateral for that level. Doesn't matter. You know, I do this for people who have a 60-degree scoliosis with 40-degree torsion of the vertebral body. And so my x-rays are doing acrobatic. But once you set up the x-rays for a true lateral and true AP of that specific level, all the other steps are absolutely identical. I just disregard what patient look like, and my eyes are only on the films, and I just use the angle and trajectory that the films get me there. But the first step is even though patients on the bed is in certain situation, I set up the AP and lateral as such that I get a true AP and lateral for that single level that I'm putting my actions on. But then it becomes easy because I disregard everything else and I follow the films. Do it all the time.
Okay.
But sometimes you see my AP like totally distorted, like doing acrobatic. It is like 30, 40 degree off in each angle, but that is the angle that gives me a true AP or lateral for that single level.
Okay. Okay. Thank you.
Mhm.
Okay, should we do this next one?
Yes, please go.
Okay, so this is a 79-year-old, very active, athletic female who presents to the pain clinic, and she says for the past 6 months, she's had this disabling low back pain. It's basically left lumbosacral with radiation into the left hip, a little bit into the left posterior leg, and pretty significant neurogenic claudication. So she's completely comfortable at rest, stands and walks for 5 minutes and just has to sit down. Then she gets much better. Exam shows painful lumbar range of motion, tenderness over the left sacroiliac joint, completely normal neurologic exam. And here's her pain diagram. And Hamid's going to show the pictures, but here's what the radiologist report of the MRI shows of L1-2 extruded disc herniation with left L2 impingement. At 2-3, she's got a left L3 impingement. 3-4, she's got moderate to severe central stenosis with a grade 1 spondy subarticular left L4 impingement and a left L4, 5 foraminal stenosis with a synovial facet cyst contributing to left 4 impingement. So as a pain doc, I'm thinking, how much of this is inflammation that I can reverse and get her maybe months of relief, which could become a management strategy. So of course, I'm trying to put needles in these targets. But I was very frustrated because I just could not get a good neurogram epidurogram with my injection. So here's my first attempt at 2-3-3-4 transforaminal epidurals. I don't have the AP from this view before my contrast, but here's what happens when I put contrast in with those needles. Just a bunch of, first I get a accidental discogram at 2-3.
That's a very good discogram, by the way.
It always happens when you're trying to do a transforaminal, but never when you're trying to get the disco.
I know.
Like that's
And
me.
just from a pain doc's perspective, first of all, I don't think Decadron in the foramen works. I think it's pretty worthless. And so I use particulate steroid for transforaminal epidurals, which is controversial.
Can you explain to us why? That I think extremely important. I so much believe in that, like you. But can you say why I know it's your observation, but what are your thoughts that particulate works so much better than Decadron?
Okay, so over the years, surgeons have told me when I put, Depomedrol in there, they can see it weeks and months later when they're doing surgery. So it tells me it's there and it's releasing this particles long, over the time. Decadron is water and it's just gone. And so in the mid 2000s, there were many reports of cervical catastrophes with transforaminal cervical particulate steroid injections with complete infarction of the brain stem and everything else. Horrible. And so everybody got super nervous about particulates in the foramen. And these paralysis cases also happen in the thoracolumbar region. So across the pain world, everybody says, let's not use particulates in the foramen. I kind of bought into that for a little while, and I just kept hearing from my patients that epidural did not help me with Decadron. And even though there's some data that says it's as good, I just don't believe it. So I went back to particulates. I've also been an expert on several paralysis cases, and I looked at the images. What dawned on me is that if you interpret the epidurogram, the injection of contrast correctly, you will not inject a radiculomedullary artery. you should be able to prevent that from happening. So I do a ton of epidurals with particulate. I've never had a problem, and I put a lot of contrast in, so I know exactly where that medicine is going to go. Anyway, for this, higher up in the lumbar foramen, I always want to be below the root because the radiculomedullary artery might be in that under that pedicle, especially at 1, 2, and 2, 3. So at the 2, 3 level, you can see my needle is under the root, and I get a discogram, and then I still don't get a good. I'm at the base of the pedicle at 3, 4, trying to get a L3 neurogram. That doesn't really show up, so it's very frustrating. And then I just didn't think I hit the target on this one. There's more contrast, it's just not very good. Anyway, she got a little bit of relief. I come back later. Here's the lateral. So you can see I'm in the ventral epidural space there with some steroid and contrast. So a little bit of hitting the target. Like 2 weeks later, I try.
I'm sorry, can I stop you? I'm really interested in the thing you just mentioned. How
Sure.
do you prevent the reticulomedullary artery when you mentioned you try to hug the medial and inferior border of the pedicle, and that's how you avoid the reticulomedullary artery? I'm just curious about that.
Yeah, so it's really an interesting history. In the 90s, when we all were starting to use fluoro for this, and I kind of started way back then, we were taught to hit the 6 o'clock position at the base of the pedicle, and the end point of our needle was the vertebral body. So we were right there in that what's called the safe triangle. And here we're above the root. We get a great neurogram, great anterior epidurogram. It works great. But then cadaveric studies showed that the radiculomedullary artery is often in that location, and it's much less likely to be lower in the foramen. So then people started going the Kanban triangle approach, but it's much more difficult to get adequate spread of medication below the root. For whatever reason, there's just tissue down there that prevents you from getting a really good neurogram and epidurogram many times. So my practice, what I started to do was in 5-1 and 4-5, I'm pretty comfortable being at the base of the pedicle if I get a good, picture. Higher up in the foramen, I think it's more likely that a radiculomedullary artery might be there, especially at 1, 2. So I get more nervous when I try to do Kanban triangle and below the root. I still interpret my epidurograms, but it's just more nerve-wracking up there with particulate steroid. Did that answer your question?
Yeah. Thanks very much. Appreciate that.
Sure. Okay, so here's my 2 weeks later. So here, this is a crappy picture, but you can see my needles are at the pedicle. Here's the 3. No, this is a 4 root because I'm at 4, 5 here. And then on lateral, I really do get nice spread of medicine at multiple levels. So I'm putting in a fair amount of volume because I want to get the steroid to go all through there. Anyway, she just gets, a couple of weeks of relief, and then she can't stand and walk anymore. So I sent her over to Hamid, and Hamid, you can take over and tell me what you think.
Well, let me just share my screen with you.
Yeah,
And
I'll stop sharing.
So, you guys remember partner with patient and find out what they want and tailor what you are going to do to what their wishes are, not to what your capacity is. Are you guys able to see my screen?
Yes.
Yes.
Let me tell you, technically, I can do a 5-level fusion under 2 hours, send this patient home within a day or two to out of the hospital. And I can as well do a segmented stage kind of procedure. And for this patient, when she came to me, the vast majority of the pain was right on the sacroiliac joint. Now, obviously, we know that sacroiliac joint and lumbar problems, they cover each other. You can have them both, and many times one aggravate the other, and so on. Another thing that I noticed in this patient specifically, David, I know that you have a personal connection to this patient, right?
Right.
Okay, so that but you have to, as a provider, we have to include that in our formula. She's a high demanding patient. She's very aware, she's very intelligent. She's, they say the doctors are worst patient. This goes in that category that she's extremely intelligent and she has a well-read and but as well, she has a very specific kind of understanding. She sort of knows what's going on and she knows what she wants. And it's a sort of, I'm just trying to help her there, not impose my views on her. So I cautiously talk to this patient, you have a scoliosis. We could fix that, but that is a bigger surgery. You will feel miserable initially, but that initially feeling miserable is 1/4 and 1/10 of the open surgery, but it's not like a surgery that Mayo says you need 2 years to recover. But the first few months, you're realistically going to feel miserable. I do believe that scoliosis contributes to your symptom in a significant way, but most of the symptoms were actually on the sacroiliac joint and provocation test was positive. Then I believe, David, I sent the patient back to you for sacroiliac joint injection, correct?
Yes.
And not surprisingly, actually, the results were positive. She had a very good result from injection. My opinion, my experience is, if they have back problem and sacroiliac joint problem, and usually sacroiliac joint is a consequence of the scoliosis, but still, no matter what, it seems that most of her symptoms improved with sacroiliac joint injection. And I don't trust anybody doing that better than you guys in Neuro doing the sacroiliac joint injection. So I discussed the options with the patient. And I described what kind of correction I would have for lumbar spine, what kind of correction I would have for sacroiliac joint. And we decided together to approach the sacroiliac joint first. But I'm going to open the floor for you guys. Again, there is no right or wrong answer. I want to go around and ask you guys, now, based on the information you have, Peter, what option would you give the patient?
Just to make sure, was a iliosacroiliac joint injection done as well?
Yes, and it was positive.
Well, I have no experience with sacroiliac joint fusion. Those patients I treated in this area were few, and their continuous or repetitive injections were almost sufficient.
So, but for the scoliosis and the lumbar symptoms,
yeah, that's a different story.
Yeah, would you do a multi-level fusion, scoliosis correction, and so on? Let me go back and forth so you see this is not a trivial scoliosis. This is quite significant scoliosis. As you see, listhesis, stenosis, and I can show you as well the MRI. Let's see if I have the MRI here. There's significant stenosis as well involved here. Now I have so many pictures, it's hard to find the right one. Let me go and open another window so I can show you the actual MRI. So would you do a scoliosis surgery? What do you think, Peter?
Well, honestly, I don't know. I cannot tell what the chances of clinical benefit would be.
Okay, so let's go around and Akshay, what do you think?
Obviously, once the SI is dealt with, can you say primarily it's foraminal symptoms that are going on along with back pain? Hello?
Yeah, we hear you. David, what do you think?
Well, when she stands and walks, she has this left lumbosacral pain that gets very intense and then is relieved with sitting. And then she's pretty comfortable when she sits, but she wants to walk and be active. And then she has a little bit of posterior leg pain down to her calf also. So she's got more than just this sacroiliac pain, but primarily she says it's my sacroiliac area and my left hip. Puts her hand right there.
Is there Is there an axial image in the MRI that we could see in the lower 4 to S1 area? That
I
could
just was looking for that. I think we have I think the MRI was from outside. I don't have access to that, but tell me what you are looking for and I tell you. I think
Well-
there is a stenosis there. There is clearly the spinal canal and stenosis more pronounced in the L3, 4, 5.
Hey, can I say one thing? So, you know, she did have an SI fusion 4 months ago. She called me like last week and she goes, so my pain that I had before the fusion is exactly like it is after the fusion. She had post-op pain and she got better. And she says, it just didn't make me worse, but it didn't get the pain that I had under control. I still can't stand and I can't walk.
Okay. Well, it's probably a combination of her lumbar stenosis along with the SI joint symptom. It sounds like, obviously, if she's the SI joint, if it's classic, could be dealt with first, and then if the stenotic symptoms of her, back and hip pain continue from that, maybe an MIS decompression would be beneficial. Rather than, correction of scoliosis could be done, but at the same time, her symptoms seem to be very specific in the lower lumbosacral area. That's what from hearing from you.
Yeah, left hip, left lumbosacral area, left low back, basically. So kind of a broad left-sided lumbar area.
I'm sorry, just to, I think my understanding here is I think MRI would be really curious to see, but I think her pain, what I can understand in the lumbosacral region is secondary to the lumbosacral sprain stretch in the setting of a dextroscoliosis curve. And I think personally, probably that's what happens in most of these people when they come in, or their rib is touching their pelvis. I don't know how much pelvic obliquity is in there. So I would be curious to see, those kind of issues. Generally, these females have typical presentation of, contralateral to their curve, excruciating pain, and that's typical presentation that they put their hand on. So definitely scoliosis, inherently is the major issue in this patient, and I would be curious to see the MRI.
And one point, when I first saw her, my impression was that she had a left L2 radiculopathy, and she does have an impingement of L2, and she had that kind of hip and groin pattern.
Okay.
To a significant
I can
degree.
tell you from my exam, patient has pain that correspond to all these levels. Patient has radiculopathy as well that is scattered all around, but most pronounced corresponding to lower 3 levels, and has claudication symptoms. Now, the reason I decided to or offer the patient or encourage the patient to get the sacroiliac joint, because most of the pain was literally there, and the injection results were positive, and that fixing that sacroiliac joint was a 25-minute procedure, a day surgery. So it is a low risk, a possibly high yield. In this case, we didn't have the yield. But so that is what it was. I never doubted that a significant part of patient symptoms is coming from scoliosis. And let me show you again, go back to this picture here. This is what I would like to do with this patient. A 5-level, and this patient looked before the surgery, as you see here, very similar. Very similar. And I do 5 to 7 of that a month. People who are older, they are refused by other surgeon to get the surgery. And I have clinical result, it works. But in this specific case, David, please don't say that to the patient.
Yeah.
It is her personality, she's not ready for it yet.
Yeah.
Whenever she's ready, meaning coming to me, say, doctor, I don't care what you do, help me.
Yep.
She has still a little bit of a doubt about, do I want the surgery, or can you guarantee me that I will have the result, and so on? Am I going to get better? And if I don't, I'm going to make sure you know that I'm not happy, and so on. She's just not. I weigh the option for the patient. she is just not ready. When she's ready, I take her and I fix her, either staged or in one. Because let's go back here. Very similar. I have a track record.
Yep.
Even
Let
in
me,
one
let me
age-
ask you, Hamid and Burhan both, you know, is because obviously we see a lot of in this picture and others components of, you know, foraminal stenosis,
Mhm.
middle stenosis, spondylolisthesis, facet joint issues. But in the midst of all of this, you know, how are you able to tease out that this is the scoliosis is the main issue rather than could it be a combination of these issues, you know, or, you know, maybe, you know, so how do you kind of tease out in your mind that this is what's going on? And I think this is the problem first rather than, you know, addressing it one level or other level. Because sometimes they'll say, okay, my leg hurts. They'll give you a particular pattern, but at the same time, you know, it's other symptoms are non-specific.
Well, Burhan, go ahead. You take the first shot.
Thanks. Yeah, I think it's a very good question. Sometimes they have an amalgamation of all these presentations and complaints. I think what I've done and I've learned over time is I would ask them, okay, I understand you have these and these complaints. What is your major issue that is, if I would take away that, they'll make your quality of life better? That's what I would do. I mean, but Dr. Abbasi is the expert on that.
Yeah, I agree. And coming back to that, it is always a combination. It's almost, you know, it's just and it is facets, it is the disc, it is the foraminal stenosis. Practically everything that can be wrong in somebody's spine is wrong here. But what is the procedure that can address most of the problem? In my opinion, what's really going on here, that this continuous, you know, the inflammation that going on from unphysiologic motion and the bad disc and more material pushed out toward the foramen. I think interbody and posterolateral fusion, at least in my experience, can address most of them. It is not an easy surgery, and definitely open surgery for, and she's, how old is she again, David? Is 80 years old, right?
She's now 79. And by the way, two spine surgeons in Florida did recommend multi-level fusion, but the open technique, the 5-hour, 6-hour case or longer.
Yeah.
And she declined.
Yeah. So she need to be ready for that surgery and committed. When she is, then I will discuss either doing a stage, doing 3 to 1, or all of it at the same time, depending on what she really wants, what she's willing to invest in that. And one of the things I learned the hard way, never, ever try to convince the patient in a situation like that they should have a surgery, ever. This is what I learned the hard way, because then they always come back at you that, you know, that they didn't want it and they were convinced or they were promised things that you never did and so on.
That is thanks for reinforcing that. I completely
Could
agree.
you repeat,
Recently,
sir, could you repeat that? You never ever tell someone to have what type of surgery, sir? Sorry to
No, in a
disturb.
situation like that, it's complex and the patient is really not sure if they want to really go for the surgery or not. I never try to force the patient or convince them that the surgery is the only thing that can help them.
Okay, and what types of surgery can we offer to this patient?
Well, this is a different patient. And again, I do 5 to 7 of these surgeries a month. I have a very good track record. But the same patient, if the symptoms are mostly can be attributed to 1 level or 2 level or 3 level, the same patient get a limited surgery. Let's go back there. So this is a different patient, very similar, but the symptoms were different. So I did a limited surgery, a 3 level rather than a multi-level. It's nothing violent about it. It doesn't let me know. Show that.
You may click on learn more and then it will show another option. Learn more and then
See the
leave.
photo. Okay, yeah, okay. So yeah, so So I can do a limited, oh, why have I these pictures here? That's not what meant to be, okay. So, that you have options. And what I'm telling you, it may not be my surgery, but you can do anterior, you can do posterolateral, you have lots of options, but you have to tailor it to what patient situation is. And again, I guide the patient and I see what they want. But so coming back to that, I know that David, you want to present this because probably she's calling you every other day and complain how miserable she is and how you didn't help her or something. I know.
No, she's
Right.
actually been, I haven't heard from her for many months, and
Oh,
she
wow.
called me last
Good,
week.
Good.
But you're right, she has kind of unrealistic expectations. She wants to be like a teenager again and no pain, and athletic.
And yeah,
It's
you
just
know,
not gonna happen. She's got a very serious, complicated spine problem that she doesn't really get. I think.
no, the word I used to her that I can correct the scoliosis with this statistic. This is my statistic. I can do a stage versus all at once with this statistic. I presented her the statistic, and then whenever that is enough for her, I'm happy to take on this. So I haven't given up on her.
Yeah, and I think what I would tell her is, your options are limit your activity and live a quiet life, or maybe go ahead and.
She won't. I know her, both of us, we know her. She won't be living a quiet life. She wants to go marathon or
Exactly.
and so on. So, but let's take other opinion, okay? This 11:07, we have to review few cases with Dr. Gupti, and then I have a TV interview. By the way, Mike, did you push it to 11:45, the TV interview?
I did.
Okay, good. So we have a little time, but let's wrap it up and say, anybody else, any other, kind of input here? Anything else you should consider?
One little input. I think that in this situation, I would probably really look for the specific symptoms and go shorter when you are talking about somebody who wants to be active after this. I would perhaps do just, so by the way, do you consider the first level with the vacuum disc phenomenon as L4-5 or L5-S1? I would consider the L5-S1 actually.
So here, that seems to be 12. 1, 2, 3, 4, 5. But sometimes they have this rudimentary rib. No,
yeah.
To make it easy, it doesn't really matter. You see, look at the bottom one. You see how solid it is here, bottom
Yeah,
one?
I would leave that one alone, and I would denote the one above it as S1, and I would probably fuse just L4-5, L5-S1, and I would put cages from the right side.
Okay.
That's what I would do.
And the
I
radiologist
would
read
do
this
an olive case, and I would measure the Hounsfield units at the concerned vertebrae, which to me would be L4-5 and S1.
So see, this is what it seems to be a full vertebrae. This is almost like a Bertolotti.
Yeah, it is. It is a Bertoletti syndrome.
Yeah, I think this is a S1.
Yeah, I agree.
So she has partial sacralization of L5 is what you're saying?
Yeah, that's what I think it is, yeah.
Yeah, I think so too.
You could do a L2 to S1, or you could do a L1 to S2. It deals.
And you could do actually L4, L5, and S1. And I think that it would take most of the symptoms, and you would get a good correction if you put the cages from the right side. Correct me if I'm wrong.
No, you're right. But I still can go from the left and put the cage exactly where you want to put it from the right side. With some experience, you can do that. I can go from the left and put the cage exactly to correct that.
To the right.
But you can go as well from the right side. But I don't do that anymore. I go from the left and put the cage where I need to put the cage.
Okay.
Anything?
Hamid, I know that you are super busy.
Yeah.
I just wanted to ask you, how was your European trip?
Oh, what was great. We had a very nice, by the way, Tony was there. Is Tony still there? So Tony, I think we had a very good team, and I really enjoyed that. We have a fantastic team, very motivated. Unfortunately, we couldn't do a cadaver lab, So we did a foam lab, and that room was an abandoned OR. It was so hot, everybody was dripping a sweat, but I really liked it. We had a
So, and
fantastic team.
my next comment is I can help very much with your planned trip to Slovakia. I spoke with doctors in Prague, and I know the doctors there personally. I know
Okay.
exactly what kind of hospital it is. It is a Penta group. It's called Naborech, the hospital, and I can arrange for a lab, and we will have great experience there. I just need to have probably 2-3 months leeway so that I can work on it.
Sure, we haven't set up a date yet, but that is in plan. I'll make sure that you're in the loop. Well,
Give me the date, and I will. It will be a different experience. You'll have a lab ready, and everybody will be expecting you there.
Thank you, thank you. Well, I definitely, keep you in the loop. Now, okay, everybody, thank you very much. I really appreciate that. It is 12 minutes beyond our usual time. So actually, I'm all yours. Let's talk about your cases. John, you can actually stop the recording so we don't mix this with